I think we have to have diagnostics that actually can test for many, many infections because the clinical overlap is so great.
So dengue is a danger disease for us, especially for the children, because you know that children is a high risk group for shock and for death.
And so in many ways, climate change and the way we live definitely impacts the incidence and spread of these infections.
Welcome back to the WSPID podcast series brought to you by the World Society for Pediatric Infectious Diseases. I'm Alicia Chan, a pediatric infectious diseases specialist working in Guatemala City.
And I'm Daniel Jarovski, a pediatric infectious disease specialist working in Santa Casa de Sao Paulo, Brazil. We are your host for this episode. Today we are looking at the intersection between climate change and pediatric infectious diseases. Extreme temperatures and precipitation events are becoming more and more frequent, threatening food, water security, sanitation, infectious diseases transmission all around the globe. For instance, of the 15 indicators monitoring health hazards, exposures, and impacts of climate change, 10 of those 15 reached a concerning new record in the last year of data, which is 2024. So what challenges lie ahead in this area, and how can our field work together to make a positive impact? So to discuss this topic in depth, we are pleased to be joined by Kleber and Desiree LaBeaud.
Desiree LaBeaud is a physician, scientist, epidemiologist, and professor for the Division of Pediatric Infectious Diseases at Stanford University's School of Medicine. She studies the human health impacts of climate change, including research focused on innovative solutions to the global plastic pollution crisis. She is CEO and co-founder of HEDI Kenya, an organization connecting scientists, community residents, and public officials to improve public health and environmental conditions in Kenya.
Thank you. Happy to be here.
Kleber is an associate professor in the Department of Infectious Diseases at the Federal University of Rio Grande do Norte in Brazil. He's also an associate professor at Hospital Giselda Trigueiro. He's an international consultant of the Pan-American Health Organization for Arboviruses in Washington, D.C. And he's a member of the Technical Advisory Group for Arboviruses at the World Health Organization. Welcome to the podcast.
Hi, everyone.
Well, thank you for taking the time to join us today. Let's start with our first section. So in this section, we are talking a little bit about the changing landscape of pediatric infectious diseases in the setting of climate change that we have all felt. We're going to be discussing the rising global temperature and what the role is in the shifting disease patterns. And we're going to be talking about some examples, which our experts are very knowledgeable about: malaria, chikungunya, dengue appearing in new regions, which are regions that maybe have never seen these diseases before. And then the role of extreme weather events in disease outbreaks. So Desiree, in this global warming setting, have you seen as a scientist a shift in the presentation of diseases, especially the ones transmitted by mosquitoes, being these present in areas where previously they were not present before?
Yes. So I study mosquito-borne viruses, often called arthropod-borne viruses or arboviruses, like dengue and chikungunya. And over the last few decades, we've seen more and more increasing prevalence and incidence of these diseases. They're not just moving around the world to new places, but they're also causing more and more disease burden in the places they've always been. And this is for a lot of different reasons. These viruses are emerging and reemerging in all sorts of new regions, mostly because of the way we live on our planet. So it has a lot to do with climate change, but it also has a lot to do with the way that humans behave in the world. So first and foremost, we live in a more urban than a rural world now. So a lot of people are moving into urban settings, and with that comes sometimes crowding and decreased sanitary conditions, and that can sometimes create vector habitat for these infections. We, of course, change the world and we change the land all the time. You mentioned that. So we go in, we deforest, we reforest, we do land reclamation projects, irrigation projects, we build dams. All of this disturbs the habitat where these vectors live and also brings humans in close contact with maybe new mosquito species or new viruses and infections they haven't seen. Unfortunately, we live in a world full of war and military activity. And so that, of course, disturbs any sort of control or surveillance that was going on before. We also have a very limited vector toolkit. And so, these vectors are smart. They're constantly changing and becoming resistant to our methods. And so that's important. And then finally, we live on a very small planet, right? We can get anywhere in the world within 24 hours. And so these viruses travel in humans, either with or without symptoms. A lot of these viruses actually cause asymptomatic infections. And so you can go to a new place, be bitten by mosquitoes, then have the virus and then transport it back home with you. And if the vector mosquito exists there, then of course you can start an outbreak. And then climate change has huge impacts. Vectors are ectotherms. They are inherently temperature dependent. And so as the world warms with global warming, of course, the range where these vectors can live expands. It expands in altitude, right? And then it also expands in latitude. And so there definitely are new places. And then, of course, naive populations of humans that exist in those places that haven't been exposed to these infections. And so that has an impact. And then you mentioned extreme weather events. Of course, these infections are related to both droughts and floods. A flood makes sense. You can imagine. I studied the plastic pollution crisis and the intersection with arbovirology and arboviral disease incidents. And we know that plastic containers laying around communities can fill with rainwater during rains and floods. And of course, that can provide breeding grounds for mosquitoes. But droughts are also linked to these infections because unfortunately, many people in the world do not still have safe, reliable access to clean water. So they store water in unsafe containers that then act as breeding sites for mosquitoes when there is a lack of replenishment of safe, clean water. And so in many ways, climate change and the way we live definitely impacts the incidence and spread of these infections.
Kleber. So now moving a little bit south to Brazil, it's a country that's quite used to dealing with many viruses transmitted by arthropods. But I think that things have changed already, also for Brazilians and many other countries in South America, due to climate change. What's your opinion? What do you foresee for the close future regarding how the climate change in the southern cone, in specific Brazil, your area of clinical practice?
It's an important question when we discuss the climate change and arbovirus disease. Today, I was discussing with my students at the university about the text in a book for the 19th century. And in this book, the author comments about the climate change and the reflects in the tropical disease and Pediatrics disease or febrile disease in Rio de Janeiro city. Rio de Janeiro in the past was the capital of Brazil. And what's happened when the climate change? Of course, the climate change is an increase in the temperature of the planet. And if the temperature increase, the mosquitoes survive more than the normal time. And we expect that the disease can move from the big cities for small cities. It's what's happened with dengue. In the past, dengue was a disease of the big cities like Bangkok, Rio de Janeiro, for example. But nowadays we see the disease in small cities, in the rural areas. Is the first impact that we can see. The other impact is the presence of the Aedes mosquitoes in the cities with high altitude, like in Bolivia and in Colombia, because in the past it was almost impossible to find a dengue disease in some areas in Bolivia. But this year in 2024 and now 2025, we found dengue disease in high cities in Bolivia and in Colombia, for example. So the dengue disease expanding in all the Latin American countries. caused probably by the climate change. Of course, the poverty of the population, the plastics, helped to disseminate the disease in this country. Other change that we had seen in Latin America was the presence of the Aedes albopictus. Everybody knows that the Aedes aegypti is the principal vector of dengue, but now Aedes albopictus is present in a lot of countries in Latin America. So probably this change in the mosquito producing the important outbreak of chikungunya in Paraguay and in Brazil. The impact of the disease is that we have a lot of pregnant women viremic, and this woman transmitted the virus for the newborns, and the newborn develop a severe disease caused by chikungunya virus. So it's so important to understand the climate change. The presence of the St. Louis virus in Brazil and West Nile virus in Brazil. West Nile virus was present in North Hemisphere in the US, but nowadays the West Nile virus is present in Brazil. And we have a lot of horses infected with this virus. And in Piauí, a state in northeast of Brazil, we found encephalitis cases produced by West Nile virus. So it's the climate change produced a lot of change in the arboviral disease, and you found Aedes in Europe, and we expect that in Italy, south of Italy, Spain, and French, we can find in the next years important outbreak of arboviral disease. This is the change, and you have to be prepared to fight against this change, the climate change that produced the change in arboviral disease.
Thank you for that, Kleber. Moving on, we're going to continue talking about disease that has been very worrisome for all of us in Latin America, as you mentioned. And the dengue really has been a very important and a disease that has caused a lot of mortality. In Guatemala, we have seen a lot of kids actually very sick, and the most mortality actually happened in kids in between 9 to 15 years of age. So there's a lot of complications derivated from this disease, and we have seen more severe cases this past year. Also, we've noticed that dengue appeared in the US, and I was trained in the US, and I remember perfectly that it was a very rare diagnosis, and we used to diagnose kids with dengue coming from countries like my country, Guatemala. So I'm sure, Desiree, you agree that we have seen this changing a lot. And I don't know if you have seen cases in California, but in general in Latin America, this has been a very worrisome disease, as I was saying. So can you tell us a little bit about the link between the climate change and these dengue disease spreading so widely? It's amazing how severe the cases have been this year for us here in Latin America, in Guatemala especially. So if you can make a comment about that. I'm not sure if it's the type of dengue that we have, or it's just a more virulent virus this time. But we have seen a lot of very sick kids. So
yeah, I know. And I'm sorry to hear that. As we all know on this call, being pediatric infectious disease physicians, we know that dengue is one of the killers worldwide of children. And as you mentioned, yes, we have had dengue in California. Actually, in the US, dengue always circulates sort of in the borderlands, Texas, on the Texas-Mexico border, and then also in our Caribbean, which is Florida, right? South Florida, we always have dengue cases, autochthonous, so locally transmitted dengue and chikungunya and Zika for that matter. And then we've had Aedes aegypti and Aedes albopictus cited in California. We have a lot of vector control and a lot of vector surveillance. And so I actually sit on my local San Mateo vector mosquito control board. When we see Aedes aegypti, this is a big deal, and they go out and they eradicate. But this last year, well, in 2023, we had our first local case of dengue in California, and then last year we had cases in Southern California, in Los Angeles, and in the Pasadena area. And so it is spreading each year as it gets warmer and warmer. And I think, Aedes aegypti, the main vector that we worry about where we are, is really, really likes it hot. Temperature. Each mosquito has its own sort of optimal temperature at which its physiology functions the best. And so Aedes aegypti is around 29 degrees Celsius. So it really does prefer it hot. And so as the world warms, it gets just better and better at transmitting with the diseases that it does. And the worry is, and the predictions is that as the world warms, more and more of the world is going to be able to actually transmit Aedes aegypti vectored infections for year round, right? And I actually worry about last year and it being such horrible years. I wonder if you guys could tell me, do you feel like there were more than one dengue season in the year? Because what I worry about now is that we're going to have a year-round dengue transmission. And we know that when children and anyone who gets dengue, when they get, their second infection, they're more likely, not always, but more likely to have more severe disease. And so I worry what we're seeing is overlapping dengue disease outbreaks. And so people are having more and more severe dengue because this vector can transmit year-round. I'd love to understand if you guys think that's what's happening.
In Guatemala, definitely is year-round, the transmission. I mean, we never stop having cases. Of course, there are some months where the transmission is super high and we see most of the cases. So last year, probably it was right in the middle of the year, which tends to be a little bit warmer and humid in Guatemala. But I'm sure Kleber and Daniel have maybe another comment about when do they see most dengue, if they ever see dengue more frequently anytime during the year, and if they feel like this is happening, because I think you're right.
Yes, in Brazil, we have 5 regions in north of the country and in south of the country. And in the past, until 2021, for example, the south region didn't see cases of dengue disease. In 3 states, Santa Catarina, Paraná, and Rio Grande do Sul, no dengue cases was notified for the health authorities. But in the last year, we have a lot of cases in the south region of the country, probably because the temperature is a little bit high. The other aspect is because the doctors all the doctors are not training about how to treat dengue disease. And what's happened that we saw a lot of death in children, in adults, and in older people. We saw a lot of death caused by dengue, because dengue is not like other infectious disease. Dengue is a particular disease. So it's the disease that if the fever goes down, it's time to treat the patient. It's not happening with the other infectious disease. We ever say to the mother, if the fever continues, please come back to the hospital. But in dengue is different. If the temperatures go down, it's time to go back. And the mother is not training to do this. So if you don't say this for the mother stay at home with the kid, and the children may develop a shock, a hypovolemic shock, and die in the next 24 hours or 36 hours. So it's a different disease, and you have to train these families, the doctors, the nurses, about how to treat the dengue, because when dengue goes to a new area, it's so bad. In northeast of the country, probably the doctors know, and probably the students at the university see a lot of dengue cases and maybe training. But at south is different. It's like in US, I think, and probably this may occur in Europe. because the doctors in Europe are not training about how to treat dengue. So dengue is a dangerous disease for us, especially for the children, because you know that children is a high risk group for shock and for death.
Yeah, and can I add on to that? So I've been working in Kenya for 20 years, and we've been uncovering the burden of these mosquito-borne viruses there and shown that Kenya is actually hyper-endemic for dengue. We have all 4 serotypes circulating. Now, we don't have the incidence of severe disease, but we definitely have a lot of dengue. And just like you mentioned about the south of Brazil, I also feel in Sub-Saharan Africa, we're very underprepared for dengue because although, we have the mosquito species, the climate is warming, and there's going to be more and more dengue burden across the continent. We don't really have the surveillance and control. Dengue is not a reported condition. There's no testing that happens in health centers for dengue, so there are not widely available diagnostics. Clinicians, healthcare providers are not trained on this disease, just as Dr. Liz was just saying. So, there may be cases of dengue that are circulating and coming in, but there's no testing that's done, so you don't rule in the infection, and the healthcare provider doesn't even think about dengue because they're trained to just rule in malaria. And then also, although we've shown that there's dengue in patients and there's dengue in the vector mosquitoes, all of the vector control that's done is really targeted towards malaria vector control, which is very different. Of course, Anopheles gambiae bites at night, insecticide-treated nets protect you, but this, of course, doesn't work for day-biting Aedes mosquitoes that are transmitting dengue. And so on the whole, I feel like the African continent is unprepared for the onslaught of more and more dengue burden, which is coming as the world warms.
Let me try to put things from different perspectives. So we've seen that the climate change is increasing the range of Aedes mosquitoes. Pediatric cases of dengue are increasing in unexpected areas. But I'd like to hear your opinion from Desiree, working in the Northern Hemisphere in the States, how this change in the dengue epidemiology or arboviruses epidemiology impact in the daily clinical activities of those students and doctors that are used to a, let's call, dengue-free region. So how did it impact, and what are the challenges you're facing in your country, in your region? And Kleber, in your case, I would like to hear your opinion regarding the other arboviruses. So you mentioned about Oropushi. So from 2023, we've detected very sharp increase of Oropushi infections in Brazil. We know that it's a milder disease comparing to dengue, but how did it change the way that Brazilian, or maybe let's call South American clinicians, might see arboviral infection in this situation of a new virus circulating among the population, causing similar symptoms as dengue?
Okay, first, the new arbovirus, Oropushi. What's happened with Oropushi? Oropushi was detected in 1955 in Caribbean, and was a kind of arbovirus that was not important in South America, especially in Brazil. But what's happened now? The Oropushi spread in all the country. So almost all the states of Brazil have Oropushi disease. And Oropushi has changed. The clinical presentation of Oropushi disease has changed. What's happened? First, we have fatalities. Every day we have one more fatality of Oropushi virus. So we have about 10, probably more than 10 deaths of Oropushi in Brazil, especially in older people. But what's happening with the children? The vertical transmission. That's like Zika, not the number of cases, because we doesn't know how many Oropushi cases we have in Brazil, in reality, because we do not have a good serology to look for the pregnant woman, and the molecular test is not easy to do because Brazil is so big. The lab are not available in all the small cities to do in the newborns. But Oropushi can produce newborn disease because the virus may be transmitted by vertical transmission, and the newborn may have a microcephaly and the other abnormalities. And some newborns die at 1 or 2 months of life. So it's like Zika, and we doesn't know the reality about the vertical transmission in neuropush. Of course, the pediatricians in Brazil looks for herpes, cytomegalovirus, toxoplasmosis, Zika, but doesn't look for oropouche. I think that in the next year we will have the numbers of oropouche about this. The other thing is in oropouche disease is that the oropouche disease may produce dysautonomy in the patients, and the person may develop, for example, blurred vision and hypotension, a lot of clinical manifestation that sometimes may be severe, and probably the patient may die. And the death occur in the first days of the disease. So it's difficult for the clinician, the pediatrician, to understand what's happened with the patient and to understand that the hypotension may be produced by oropouche virus. If the patient has fever and the hypotension is a shock, is a sepsis, and the doctor will introduce antibiotics, IV fluids, etc., and not to treat the dysautonomy. So it's a new version of the disease. And when you read the first papers produced about oropouche, Dr. Francisco, the principal author, doesn't comment about the dysautonomy, because dysautonomy is a theme more recently detected in oropouche disease. And the other complication of oropouche is the relationship about the oropouche infectious disease and Guillain-Barré syndrome. In Cuba, there were a lot of Guillain-Barré syndrome, and everybody knows how difficult it is to do this diagnosis in children, because the clinical picture of Guillain-Barré syndrome in children is quite different from the adults. So the pediatrician has difficulty to do this diagnosis. So it's a challenge, oropouche. I think there's a challenge for the pediatrician because we doesn't know the clinical picture. The clinical picture in children may be like a gastroenteritis, not like a dengue fever, myalgia, and arthralgia, but a gastroenteritis, dysautonomy, and death. What's happened with the children? We doesn't know. We have to produce the clinical trials to describe the clinical pictures of oropouche disease in small children and in newborn, and of course in pregnant women, to facilitate the diagnosis in this group. So we have a lot of work to develop in oropouche. And about the West Nile virus, of course we have a West Nile virus in the US, but we don't know what's happened with West Nile virus in South American population. We are different from the North American people, and we don't know what's happened with the children in this region with West Nile virus.
So you're talking about how the clinical manifestations of oropouche look like they've changed. Do you think it's that they've really changed, or do you just think that more and more people are getting exposed, and so we're seeing sort of, less frequent clinical manifestations of oropouche as it infects more and more people?
I don't know the correct answer for your question, because the first publication about oropouche, the part of the clinical manifestation is just one paragraph. So probably the people were epidemiologists who describe a good paper about oropouche, but they focus in the virus, in the serological tests. We don't know about the clinical. But when we visit an area, last year I visited an area with oropouche, a lot of oropouche disease. We visit, in Portuguese we say as Maciço do Baturité in Ceará. It's a state close to Rio Grande do Norte. And for example, the adolescents can't use the cell phone because the light of the cell phone is not okay for the adolescents. Okay, and you think what's happened with a teenager that can't not use the cell phone? It's a problem. it's a problem because they use for 24 hours a day, 7 days a week. And I think that's a problem with the teenager can't use the cell phones. But if you ask what happened with your cell phone, they said, I can't use the cell phone. So Oropush produces this autonomy, and the eye cannot be adapted for the light. It's a clinical aspect that it was impossible to ask in the past. So the dysautonomy, because the dysautonomy was not recognized by the clinicians in the 70 years, for example.
And what about your experience in the States?
Yeah, thanks. It's so interesting. We're trying to actually, just to follow up, we're trying to do some, I mentioned that we work in Grenada, and we have a study right now where we're looking for Oropush exposure in Grenada, along with dengue and these other arboviral infections. So again, in the US, we still are not seeing wide scale transmission of these infections. And so the cases that we see of these infections, mainly, especially dengue being the most common one, are imported cases when people go and travel and they come back. And we see a few cases a year where I am on the adult side, plus the pediatric side, and so they're still fairly rare. We're always testing, and I think on the outpatient side, definitely there's more exposure, but I just do inpatient medicine, and so I would only be seeing the ones who have severe disease, and so it's a much fewer number, as you'd expect.
Just a comment about the Oropush, because the first cases, Oropush cases in Brazil, was detected only in lab. So the patient had a clinical diagnosis of dengue, collect a blood sample, send to the lab, and the tests were negative for dengue, chikungunya, and Zika. And they did the test for Oropush, and about 30% of the samples were positive for 30% of the negative samples for dengue were positive for Oropush. So we have a lot of cases, but we doesn't know about the clinical picture of these patients. So probably in US, in Puerto Rico, for example, the people who develop a febrile disease may be classified like dengue, but maybe Oropush. Because Oropushes are not testing for all, only for a small amount of samples of blood. This is the question. We have to look for Oropush to find. What's happened in Cuba? In Cuba, there were a dengue outbreak, but the samples were negative. So in March 2024, they began to test for Oropush, and a lot of samples positive for Oropush. So Cuba had an Oropush outbreak, and the clinician, and everybody knows that the clinician in Cuba are very good clinicians, thought that were dengue, not Oropush. That's the question. We have to train the clinician and the pediatrician to find the disease. Over.
Yeah, well, I think because of the disease overlap with these infections, right? I mean, it's impossible really to train the clinician. I think we have to have diagnostics that actually can test for many, many infections, because the clinical overlap is so great between all of these infections. And so we can't rely on our diagnostic, our clinical diagnosis alone to distinguish these diseases. It's impossible.
Yeah, mostly it's like fever, joint pain, red eyes, feeling bad, headache, yeah, exactly. Photophobia. They do overlap. Yeah. And I would like to hear both of you on this topic. What do you think about diagnostics? Because here in Guatemala, we only do serologies. There's a PCR that is available, but only in the national laboratory. So it takes a lot of effort to actually get the sample there. So, and then the serologists take a long time. So usually it takes at least 6 hours to get those back. So I don't see it as very effective. And as you were saying, Desiree, it's not available for everyone. So I don't know if there's something more interesting or a rapid test that you guys see as something that is feasible in these areas where the impact of having a diagnostic test might be it. I mean, might be the thing that will make a difference?
The diagnosis of arboviral disease, I think that we can think in two aspects. The first one, for managing the case, we do not need the diagnosis test. We can manage dengue disease in the children only with the epidemiological data and clinical data. And we do the hydration of the patient, look for the shock, and treat the shock. The shock in dengue is a hypovolemic shock, and we have to use IV fluids to treat this. We do not need, I repeat, we do not need a confirmation for treat a patient with dengue or chikungunya or other arboviral disease. But for the surveillance, it's important. How many dengue cases we have in US, in Guatemala, in Brazil? You have to confirm these cases, so you have to use lab. What's happened with the serology? In the past, we use the IgM test to confirm a dengue disease. What's happened? Now in Brazil, we have the yellow fever virus, Zika virus, and dengue 1, 2, 3, 4 serotypes circulating in the country. So the people may have one dengue, a second dengue, a third dengue. And in the secondary infection, the patient may not develop IgM reactivity. So the children may develop a dengue without IgM detected in the blood. This is the problem when we use IgM. So IgM may be negative in a patient with a secondary infection. The other thing is we are in 2025, and the children who were infected with Zika was in 2016, for example. So if the children had Zika and now develop dengue, may develop IgM for Zika, not for dengue. It's a cross reaction with dengue and Zika. And if the pediatrician is not well trained about the serology, may have a wrong diagnosis, because sometimes the patient here in Brazil had IgM for chikungunya, IgM for dengue, and IgM for Zika at the same time. And the question, what's happened with this patient? So it's important to use molecular test RT-PCR for detecting this virus. But for Zika, the viremia is not so high, and you have to collect the blood sample until the third day of the disease. And generally, children with Zika doesn't do the consultation in the pediatrician service in the first day of the disease. And in dengue, the viremia is present only for 5 days. So when the patient develops a severe disease, probably the viremia is not detected. So we can't do the diagnostic confirmation in this patient. And of course, the lab, we have only central labs in the country. The private lab doesn't do the molecular test for the public service, and it's a little bit difficult to do this molecular test in the public system here in Brazil. So it's difficult to do this confirmation for the patient. The rapid test is not good because the patient may have dengue with IgM and rapid test negative, maybe other infectious disease with IgM positive. So I think that you have to recommend the pediatrician not to use rapid IgM test for diagnosis of dengue disease. It's not useful and may be a wrong information if positive or negative. This is my opinion about the diagnosis in the arboviral disease. Over.
Great, thank you, Kleber. Now, Desiree, can you share with us your experience with the surveillance and early detection strategies in the countries you've worked at?
Yeah, I mean, I have a lot of things to say about diagnostics. I agree. Diagnostics for arboviral infections are truly a mess. I think that it's really tricky. Again, the clinical syndromes overlap so much. We actually really do need diagnostics, good diagnostics that are rapid and accurate and hopefully field deployable and rapid, so that we can know what our patients have. Because as more and more of these infections overlap in different regions, and dengue is one thing because you want to watch the fluids really closely, like we've talked about, right? And look for shock and manage the child really closely, right? During that period of risk. But these other infections maybe have other different outcomes. And so I actually do believe that we do need better diagnostics. And where I'm working in Kenya, it's important because right now, again, only malaria is really diagnosed. And so there's a lot of overlap with malaria and dengue in Kenya. In some of our studies, we've shown that half of the children who have dengue viremia actually also have malaria. And so we need diagnostics to rule in these infections because, again, we treat them differently, and children that are co-infected behave differently than children with single infections. And so that's important. It's important for the surveillance and control side because it's important to know what's circulating, right? Again, where I am in California, West Nile is our most common infection. It's just now coming to you, Dr. Luz, but we've had it for several years, decades. And we see West Nile disease in children. And again, it looks a lot like all the other arboviral infections. So when West Nile comes, people will be thinking it's dengue, but it's not dengue, it's West Nile. And that's a big problem because it's a completely different vector that you need to control when it's West Nile. And so I think it really is important to have truly accurate diagnostics close by. Also, I want to mention in Kenya, we're also finding this interesting phenomenon. The paradigm is that the child's bitten by the infected Aedes aegypti mosquito, they have a viremia, they mount an IgM response and then an IgG response, which of course cross-reacts with all the other viruses in that family and causes a lot of problems in future infections. But we actually find in Kenya, we have several kids, hundreds of them actually, where we've documented that they have dengue viremia and they never mount an IgG response when we follow them for a long time. And so that's interesting too. What is happening there? Why is that the case? And then what happens when they get their second dengue infection, which then looks like their primary dengue infection? And I'm sure you've probably seen this in Brazil as well. So I think there's a role for molecular diagnostics. Of course, if you can get a child in early and you have the capacity to do so, you can actually figure out what the child is infected with. And then after that, if they've seen multiple infections, it is an absolute mess, as we're talking about, because of the cross reaction and the difficulty in trying to weed that out and the limited methods we have that are very labor intensive and expensive to do that.
Yeah, definitely. I couldn't agree more.
Yeah, sometimes you get a little frustrated because you have special population patients, but also if you have an immunocompromised patient coming with fever, which happens to me all the time, it is very different for me if it's just fever and neutropenia versus a cancer patient presenting also with dengue or any other arbovirus. So I think sometimes you just want to avoid to give antibiotics if they do have a viral illness, and sometimes the diagnostics are not as good and reliable as you want them to be. And I'm sure our listeners are going to relate perfectly well with what we are discussing right now. In terms of preparedness, and we did talk a little bit about surveillance. So we try to do our surveillance. We try to collaborate with public health officials, and sending our samples, making these diseases reportable, which in Guatemala they are. All of the arboviruses are reportable diseases. I understand in Kenya they're not, but in my country they are. It takes a little bit sometimes to be diagnosed, but they are reportable. Is there the way you guys suggest we can prepare as pediatricians to better treat these patients, to better assess these patients? I'd like to hear both of you again.
Of course, it is very important to training the pediatrician to do the epidemiological and clinical diagnosis of dengue, and to treat the patient based on these two aspects. It's important to use the case definition aspects. If children come from an area that are found in Aedes and the transmission of dengue disease, the student has a fever that is 480 hours of fever until 7 days of fever, and have a headache, myalgia, arthralgia, abdominal pain, rash, and leukopenia, probably this is a dengue case. Of course, if the children is under 1 year old and has only fever, and the pediatrician doesn't find any other explanation for this fever, probably this is a dengue suspected case and have to receive the treatment for this. For treating this patient, we have to look for the hydration, offer liquids for the student, and to treat the fever with paracetamol. And here in Latin America, we use metamizole. In US, we do not use metamizole, but I don't know if in Africa you can use metamizole. But in South America, all the countries use this. We have to treat fever, and you have to inform the mother about the warning signs. What is the warning signs? The warning signs are clinical signs that inform the clinician that this student may develop shock in the next 12 until 36 hours. So if a student has warning signs, what is the warning signs? Abdominal pain, for example, vomiting, lethargy, and increase in hematocrit. And the children develop one of the signs. There are 80 warning signs in dengue. The student has to be admitted in the hospital and to receive IV fluids, 10 milliliter per kilogram in 1 hour. And the student has to be monitorizing for the next 24 or 48 hours. Because during this time, the student may develop a shock. And what's happened with the shock in dengue? The shock is very quickly, it's very rapidly, the children develop shock. Sometimes the children develop tachycardia or capillary refill time prolonged. So it's these two aspects mark the shock, because the hypotension in children is a clinical sign, a later clinical sign. So you have to look for this, and if the children develop tachycardia or a great capillary refill time, we have to use IV fluids more intensive, like 20 milliliters per kilogram in 20 minutes or 15 minutes. This is the training that you have to do for all the pediatricians in all the world, especially in areas where we found the dengue disease in children, like Caribbean and Latin American, of course, in Africa. In Africa, the possibility of a shock in the children is not so high that we found in Latin America, because we don't know, probably the people with black skin may have a minor change to develop shock in dengue. But I think that the organ compromise, like myocarditis, kidney failure, or liver failure, the people from Africa may develop it, and the doctor have to look for this to treat correctly this patient. It's important to do the differential diagnosis with other disease like leptospirosis or malaria, of course, and sepsis. But it's important to train all the pediatricians in Latin America to treat correctly dengue, because if you do not treat, if you think that the fever is not so high, so no more disease, may be dangerous for the children, and the children may die. All the reports about death in dengue in children is the same medical history. The mother goes with the children for the health test system, and the doctor doesn't recognize the severity of the disease and said to the mother, go back home and come with if your children develop fever. It's not correct in dengue. We have to look for the children without fever, not for the children with high fever, because if the children has a high fever, is in the febrile phase. We have problems in the febrile phase, like seizures, like the hydration, for example, but not shock. The shock is probably has a small chance to develop in the febrile phase, but in the effervescence phase, it's danger.
I think in Kenya, it's a quite a different experience because again, the malaria dengue overlap. So in our studies, at least at initial presentation, dengue and malaria are showing the exact same symptoms. And actually, when we've done studies of our cases of dengue in Kenya, more than 60%, 62% actually do not meet WHO clinical criteria for dengue in Kenya. And so those criteria do not work in Africa. And so I think there needs to be, more research on this, more clinical understanding of how we might rule in or rule out these infections, because it really matters. And we've actually found that what ends up happening where we're working is that many of the children end up with antibiotics that they don't need. We now, everyone knows about the antimicrobial resistance pandemic that we're all part of. And I'm sure we're seeing children in all of our clinics that have horrible susceptibility patterns for their microbes and their pathogens. And so over 90% of the kids now with a non-malarial diagnosis in Kenya are receiving antibiotics when they're febrile. And so I think, again, it's just that calling for stronger diagnostics so that we can rule in infections and then really give really excellent quality clinical care specific to that diagnosis and try and decrease the harms that we could do by offering a lot of therapies that children don't need.
So, during our conversation, we could discuss from clinical aspects, epidemiological, and the impact of global climate change on dengue, chikungunya, Oropush, and we had some perspectives from different parts of the planet. So it was a really, really fruitful conversation. Thank you very much, Dr. Desiree, Dr. Kleber. It was a great time with you, and we all enjoyed this moment, and hope to see you again very soon in the next WSPID podcast.
Yes, if any of you, Desiree or Kleber, want to say a few takeaway points, it's fine. The microphone is yours.
I'll just end. Thank you very much for this opportunity to meet all of you. It's always great to meet other pediatric infectious disease physicians across the world. I just want to say, I know we focused a lot today on mosquito-borne viral infections. We talked a lot about dengue, but of course, children are very vulnerable to climate change impacts in so many ways. They have more surface area. So heat is a big problem in children. We didn't talk about other infectious diseases, food and waterborne diseases, and their relation to child health and morbidity and mortality across the world. We focus mainly on vector-borne diseases, but there are so many ways that climate change is actually impacting child health. And I think as pediatric infectious disease physicians, in particular, respiratory, food and waterborne, and then vector-borne diseases are the ones that are probably highest on the list. And I think as physicians who take care of this vulnerable group of amazing children in the world, I think we need to be always thinking about that and thinking about the ways that we can protect our children, recognizing that climate change already exacerbates existing health inequities. So the children who come to our clinics who are poor or more marginalized are probably more likely to have those climate change impacts impacting their lives, and then also more likely to suffer from them. And so I think that's something we always need to be thinking about and working toward providing just excellent health for children across the world.
Thanks for the invitation, for this great opportunity to talk for a lot of pediatricians around the world. It's important to do this. It's important to inform the people about dengue, because dengue is a neglected disease, and you have to discuss a lot for training the pediatrician. And if you want, you can visit the webpage of the Pan American Health Organization, found the guidelines about dengue. It's good. It's read to use. It's easy to read, and you can use in all level of complexity at the primary care, secondary care, or tertiary care. The PAHO is producing a text for how to treat the severe case, and I think that next year you can look for this test in the PAHO webpage. Thanks again for this invitation. It's a pleasure to discuss with Dr. LaBeaud and Alicia and Daniel.
And that's the end of today's episode. Thank you again. To find further resources and educational content, you can visit the Global e-learning portal on the WSPID website, your hub for pediatric infectious disease insight.
Whether you are on your way to or from work or doing the school pickup, thank you for listening to the WSPID podcast. Make sure you're subscribed on your favorite podcast platform so you don't miss an episode. Please share the podcast with your colleagues and leave us a review, and be sure to tune in next time.